Alright guys, welcome to the Pharmacology 2 series on hyperlipidemia drugs. Coronary heart disease is the leading cause of death worldwide. Coronary heart disease can be associated with high LDL cholesterol, high total cholesterol, which does include a component of the triglyceride level, and also correlated with low HDL cholesterol. So HDL cholesterol can be protective, and low levels of HDL are correlated with coronary heart disease, whereas high HDL levels are not. High HDL levels, again, are protective, whereas LDL cholesterol is not protective. High LDL cholesterol is a bad thing. Other risk factors or things that can contribute to the development of coronary heart disease include lifestyle choices like smoking, obesity, as well as other conditions including hypertension, diabetes mellitus, and chronic kidney disease. And then advanced age is also another risk factor for coronary heart disease. So hypercholesterolemia, or high cholesterol, is a risk factor for coronary heart disease. There are multiple different things that can cause hypercholesterolemia, or high serum cholesterol. There are lifestyle factors that can contribute to the development of high cholesterol. Lifestyle factors include things like a lack of exercise, a diet that's high in saturated fats. And you'll notice that both of those things contribute to obesity, which is another risk factor. So a lack of exercise as well as a diet high in saturated fats is dangerous for multiple different reasons. Hypercholesterolemia can also be caused by a genetic defect in lipoprotein metabolism. So there are inherent genetic factors that contribute to high cholesterol. It is not simply diet-based, which some patients think that just changing the diet is always going to be enough to fix hypercholesterolemia. And while changing the diet is helpful, and we always recommend lifestyle modifications, including a diet low in saturated fats, frequently that is not enough, and patients will need medication because of the fact that there are genetic defects in the metabolism of fats that lead to this development of high cholesterol. Now, in reality, most patients have a combination of these. Right? With most people, there are lifestyle factors as well as genetic inherent factors that contribute to the development of the high cholesterol. Therapy, including, again, lifestyle modifications and pharmacotherapy, is effective at reducing coronary heart disease mortality by a considerable percentage. Again, I'll mention lifestyle modifications are good. They are helpful, but they do not replace the need for pharmacotherapy if the patient falls into any of 4 statin benefit groups. So coming up, I'll show you the treatment guidelines, and I'll show you an algorithm, and it lists 4 specific groups. They're called statin benefit groups because these patients benefit from statin therapy, or therapy with a class of drugs that are called statins. So patients who fall into one of these 4 statin benefit groups always need to have some sort of drug therapy in conjunction with the lifestyle modifications. These next 3 slides, I've included clips from the 2018 AHA-ACC guidelines on the treatment of or management of blood cholesterol. These are like the top 10 take-home messages. I'm not going to go through and read each one with you, but these are really beneficial to go back and look at the end of the lecture after you've learned about some of the drugs that we use to treat high cholesterol or high triglycerides. Go back and look at these, and it kind of gives you some guidelines of what to use when. For example, number 2 here, it says, in patients with clinical ASCVD, which ASCVD we'll be using that acronym a lot today. That stands for atherosclerotic cardiovascular disease. So in patients with clinical atherosclerotic cardiovascular disease, reduce LDL cholesterol with high intensity statin therapy, or the maximally tolerated statin therapy. So we'll learn that statins are like the drug of choice, the primary drug that we typically use to lower LDL cholesterol. And we break the statins up into high intensity, moderate intensity, and then just our low intensity normal statins. So this is saying in patients who already have active, clinical atherosclerotic cardiovascular disease, that right off the bat, you need to start them on a high intensity statin. Or again, note it says whatever they can tolerate, the maximum that they can tolerate as far as statin therapy goes. Looking at number 3, in very high risk atherosclerotic cardiovascular disease. So in patients who have atherosclerotic cardiovascular disease and then have some additional risk factors, which we'll talk about in a minute. In these patients, you should use an LDL threshold of 70 milligrams per deciliter. So that's a little bit lower of a target for the LDL cholesterol, but in these high-risk patients, the LDL threshold of 70 should be used when considering if we should add additional therapy to the statin. So because they have ASCVD, they should already be on a statin. But if they also have one of these high-risk characteristics, this is saying that as if the LDL cholesterol is greater than 70, we need to add another agent to the statin. So it says add a non-statin, which we've got multiple different non-statins that we'll talk about. Okay, but these continue. For this slide here, you see that there are more of them, just goes through more specifics. About when to start, like for example here it talks about starting moderate intensity therapy. Before we saw high intensity therapy. Those were patients who already had atherosclerotic cardiovascular disease. Here, the patient doesn't have ASCVD, but they have a high risk score. So we'll talk about the fact that we calculate the 10-year ASCVD risk. And based on their risk score, that can guide the therapy choice that we use. So in this case, it's talking about patients with a specific ASCVD risk score being started on moderate intensity statin therapy versus the high intensity that we just saw with the patients who already have ASCVD. Okay, so again, go through, read all of these. And then the last few are here on this slide. These will make more sense to you after the lecture, but they are really helpful. There are a couple things I want to talk about on this flowchart. This flowchart is from Hyperlipidemia Guidelines. It's also in your textbook, so you do have a copy of this in your textbook. But a couple things. One, up here at the top, this little box is talking about the definition of high intensity statin therapy and moderate intensity statin therapy. And looking at those guidelines, we just saw there are very specific situations where you would start high intensity versus when you would start moderate intensity. And in both cases, we're talking about statin therapy. So we're talking about a drug class that we kind of like nickname the statins. Technically, they are HMG-CoA reductase inhibitors. We'll look at them next. But when starting a statin, there are very specific rules on when to start certain ones. So the high intensity statins are defined as lowering LDL cholesterol by greater than 50%. So that includes atorvastatin, and rosuvastatin. Those are our strongest statins. They're both high intensity. Moderate intensity statins lower LDL cholesterol between 30 and 50%. There are multiple statins that are in this moderate intensity group. Simvastatin is one of them. Pitavastatin is one of them. Lovastatin and pravastatin. So I'm not going to write the whole word because I'm writing with my finger. The pen's not working, so I'm writing huge right now. So I can't fit the whole words, but you'll see the names of the actual drugs on the next slide. But simvastatin, pitavastatin, lovastatin, and pravastatin are all moderate intensity, whereas atorvastatin and rosuvastatin are really strong, high intensity statins. Here you see that we are calculating or looking at different risk factors that patients might have for developing coronary heart disease. And we use that ASCVD calculator to look at their risk score. And here you have 4 different statin groups, or 4 different groups where, based on specific characteristics, the patient does have to start on a statin therapy. Up here, right, if the person is not in one of these ASCVD risk groups, you don't have to start them directly on statin therapy. But notice there are other caveats here. If they happen to have very high triglycerides, so they might not fit any of those statin categories, but say the triglycerides up here, triglycerides are over 500 milligrams per deciliter. That's hypertriglyceridemia. They're really high triglycerides. So in that case, they need to be started on a medication that specifically targets triglycerides. That happens to be the Fibrates or Niacin, which we'll talk about both of those in a little bit. If not, if the triglycerides are not over that mark, then we just counsel them on healthy living, emphasize healthy lifestyle choices, and then we recheck their ASCVD risk again in 4 to 6 years. Now, if they do fall into one of these statin groups, then we start a statin. Looking at this, the different statin groups are that they actually have clinical atherosclerotic cardiovascular disease, that they had an LDL cholesterol greater than 199. That might say 190. Sorry, my eyes are not working really well right now. That's why I'm wearing my glasses, and I can't really see the screen. It's super, super blurry, so I'm kind of guessing at what I'm seeing. So you'll have to forgive me, you guys. I'm sure you can actually read right now. But an LDL cholesterol over a certain value. Or if they have diabetes and are in an elderly age range, or if their estimated ASCVD risk score is over a certain percent. So if they fall into any of those 4 situations, then you can see you're going to go, these are the statin groups, so they're going to end up on some sort of a statin. But you continue down the algorithm and answer the questions, and then you'll find out, okay, are they going to be on a high intensity statin like atorvastatin or rosuvastatin, or are they going to be on a moderate intensity statin? Then you reassess your patient and see, was this beneficial, or do we need to up the dose of the drug or add another drug? Do we need to maximize the effectiveness of therapy in some way? We're going to spend the rest of the lecture going through the different types of drugs, the different drug classes that we use to treat high cholesterol or high triglycerides. We'll start with the kind of standard of therapy, the most important drugs that we see here, and that is the HMG-CoA reductase inhibitors. This is what we're referring to when we say these statins. And the reason for that is that all of the actual drug names end in statin. So it's easy to just call these the statins. That's a lot easier to say than HMG-CoA reductase inhibitors. Statins are first-line therapy in patients who have an elevated risk of atherosclerotic cardiovascular disease. We just saw that there are numerous statins that all have different intensity. Rosuvastatin and atorvastatin are the most potent, followed by simvastatin and pitavastatin, and then the others kind of trickle down from there. The way that the statins work is by inhibiting the specific enzyme. They inhibit HMG-CoA reductase. This enzyme is necessary for the intracellular synthesis of cholesterol. This enzyme is utilized in the rate-limiting step of the synthesis of cholesterol. So by inhibiting the enzyme, you decrease the intracellular synthesis of cholesterol. So first off, cells make less cholesterol. So there's one way that the cholesterol is decreased. The cell makes less of it. Also, because the cell doesn't have enough cholesterol, which cells use cholesterol, right? Cholesterol is beneficial. But because the cell does not have enough cholesterol inside, it's going to try and take up cholesterol. So it's going to say, okay, there's cholesterol in the blood and I really need cholesterol, so let me take some of it out of the bloodstream. The way that the cell does this is by upregulating the number of surface LDL receptors that it has. So it puts more LDL receptors in its plasma membrane. That way the cell can bind and internalize cholesterol. As the cell is doing this, it's taking the cholesterol out of the bloodstream, right? So it's removing cholesterol from the blood, and that decreases the amount of cholesterol that's present in the blood. So they work kind of in two ways. One, the cell makes less cholesterol. If you make less cholesterol, you have less cholesterol in the body. And then also there's a shift in the location of cholesterol. So instead of the cholesterol being in the serum, which is where we have it causing problems, it shifts intracellularly. Okay, so overall what happens is we see a decrease in plasma cholesterol levels. Statins are used as first-line treatment for patients who fall into any of those 4 statin benefit groups. We just looked at those, right? So if the LDL cholesterol is above a certain point, if their ASCVD risk score is above a certain point, if they have active ASCVD, right? Those are all examples of times when statins are first-line drug of choice. They are effective in all types of hypercholesterolemia, but there is kind of an asterisk or a caveat in patients who are homozygous for type 2 familial hypercholesterolemia. In these patients, if they're homozygous, they do not make surface LDL receptors. So you kind of lose part of the benefit of the statins. Remember that part of this benefit comes because the cell upregulates the number of surface LDL receptors that it has, and that helps it take cholesterol out of the bloodstream. If the patient doesn't have these receptors, then it's not able to upregulate them. So they can still have some LDL benefiting response because the cells are making less cholesterol, but they're not as beneficial in this specific patient. Both lovastatin and simvastatin are prodrugs that are hydrolyzed into the active form of the drug. The other drugs are given in their active form. All of the statins are available in oral tablets. They are also all metabolized by CYP enzymes except for pravastatin. So in patients with hepatic insufficiency, the drug can accumulate. There can be statin accumulation that occurs. But we'll see down here that the drug's contraindicated in active liver disease. So if a patient has severe active liver disease, then they shouldn't be on the statin anyways, so you won't see that accumulation. Also important kinetically is that statins increase the effect of warfarin. We just talked about warfarin in the last chapter, and you guys know that small changes in warfarin can have a big clinical effect. So this is really important. If you have a patient who's already stabilized on warfarin and you add a statin, it is possible that the warfarin will cause more anticoagulation and you'll have an increased INR in that patient, in which case the patient's at risk for bleeding episodes. So if you have a patient on warfarin, you need to monitor the INR when you're starting the statin to see what kind of an effect it has, and then also if you adjust the dose. So if you're increasing the dose of the statin, you need to check the INR again to see if that changed how much the warfarin is thinning the blood. And then also be cautious, right? Look out for things that would signal that the blood is too thin, that the patient is bleeding. Adverse drug effects of statins include elevated liver enzymes. The statins can be hepatotoxic. They can damage the liver. So LFTs are typically monitored prior to initiating therapy. So you get that baseline and make sure that the patient has normal liver function. And then also LFTs will be monitored again if the patient has symptoms that are consistent with liver dysfunction. So if the patient is jaundiced or any type of symptom that would tell you that there's a problem with the liver, go ahead and get liver function tests to see. And then if there is, if the LFTs are elevated or if the liver enzymes are elevated, then there's a possibility that it's the statin that's causing that and they might need to be taken off the statin. Statins are associated with myopathy. Muscle destruction can occur with statins. And it's possible that statins can cause rhabdomyolysis. Now, rhabdomyolysis is severe. This is a severe disintegration of muscle tissue, of skeletal muscle tissue. It is rare that rhabdomyolysis occurs, but it is possible. And again, it is severe. So it's something to keep an eye out for. Risk factors or things that make a patient more likely to develop rhabdo with a statin include renal insufficiency, as well as vitamin D deficiency. Patients who also have hyperthyroidism, those of advanced age, and then females are more likely than males to develop rhabdo. And then also patients who are on drugs that also have muscle adverse drug effects. So these include things like the azole antifungals, cyclosporin, erythromycin, and all of those are antimicrobials that the patient probably won't be on long term. So it's important to keep that in mind if you're just starting erythromycin for an infection, that could possibly increase the person's chance of developing rhabdo with a statin. So if you have a choice between two antimicrobial agents, it's better to choose one that is not going to increase the chance. Also, two other drugs, niacin and gemfibrozole, those also increase the chance of the patient developing rhabdo. And both of those are actually drugs that we use in cholesterol management. So we do use them with statins. We can add them onto statins, but it is important to keep in mind that does increase the chances of rhabdo. So if you're adding something to further lower cholesterol, or maybe perhaps to get triglycerides or increase HDL, if you're adding that onto a statin therapy, you need to pay special attention to muscle health. So we monitor patients for muscle complaints like muscle soreness, muscle aches. If a patient is developing muscle soreness with no explanation behind it, then plasma creatine kinase levels should be measured. And if the creatine kinase levels are above a certain point, and that signals that there is muscle destruction occurring, then the statin should be stopped. Statins are contraindicated in pregnancy. They cannot be given during pregnancy. And then they're also contraindicated in active liver disease because, again, they can be hepatotoxic themselves. All right, so we're going to change gears now and talk about niacin. Niacin can be used alone, or it can be used in combination with other agents like statins. For example, there are fixed dose combinations of long-acting niacin along with lovastatin, and then there's also long-acting niacin with simvastatin. Niacin is available by itself as well, both short-acting and long-acting versions. In order for niacin to be effective, it needs to be taken at 1.5 to 3 grams daily. This is important to make sure that patients know exactly how much of the niacin they need to take in order for it to have an effect. Niacin is effective at lowering LDL. It has a modest LDL lowering benefit though, and that's not really the primary reason that we use it. Niacin is the most effective agent at increasing HDL. And remember, HDL is actually healthy. This is good protective cholesterol. So we do want adequate HDL. Niacin is the best agent we have for increasing HDL cholesterol. It is also really effective at reducing triglycerides. It's like the second most effective agent we have for decreasing triglycerides. It decreases triglycerides by about 20 to 35%. Just to give you some perspective, the statin that has the greatest triglyceride reduction reduces triglycerides by 29%. So this is as effective at reducing triglycerides as the most effective statin is. Most statins, though, have less than a 20% reduction in triglycerides. Okay, so niacin is the best agent for increasing HDL and the second best agent for reducing triglycerides. The mechanism of action of niacin is that it inhibits lipolysis in adipose tissue or in fat tissue. Lipolysis is just the breaking down of fats, right? Lysis is to break something down, lipo like lipids. So it inhibits the breakdown of fats into free fatty acids in the adipose tissue. Typically, the fats will be broken down to free fatty acids, and those free fatty acids will get released into the bloodstream. And then the liver will use those in order to make things like triglycerides and then VLDL. So by inhibiting the freeing up of those free fatty acids, niacin ends up reducing circulating free fatty acids. Okay? Reducing the circulating free fatty acids leads to a reduced formation of triglycerides and VLDL in the liver. And then ultimately that decreasing the VLDL will end up decreasing serum LDL cholesterol. Now, I will tell you guys that their niacin has not been shown to reduce the risk of ASCVD events. So when it's added to statins. So statins alone have been proven to decrease the risk of ASCVD events. Adding niacin to statins has not been proven to reduce those events. It does further reduce LDL, it does reduce triglycerides, it does increase HDL, but we don't have like double-blind, placebo-controlled studies that show adding niacin has furthered the statin's ability to reduce ASCVD events. Just kind of have that in the back of your mind. We still add it to statins, and we still use it. Niacin can be used in familial hyperlipidemia and then also in severe hypercholesterolemia. We'll typically combine it with other agents. So it'll be used with other agents like a statin. The most common adverse drug effect associated with niacin is a severe cutaneous flushing. And this is really common. But just this warmth and redness that just flushes up the chest and the face, and it is really bothersome. There are a few things that can be done to try and mitigate this flushing because again, it's bothersome. It really bothers patients. So a couple things. One, taking aspirin before taking the dose of niacin. The reason that this works is because the flushing is mediated by prostaglandin. Aspirin inhibits that. So taking aspirin a little bit before taking like a half an hour, taking aspirin a little bit before taking the niacin can help mitigate that flushing. It also tends to cause some nausea and abdominal pain. This is more frequent in the beginning of therapy. You can help mediate that by doing a slow titration of the dose. You start the patient at 500 milligrams, then 1,000 milligrams, then 1,500 milligrams. Also, extended release formulations. Extended release formulations tend to help decrease the flushing effect as well. Niacin does inhibit the active tubular secretion of uric acid in the kidneys. Remember, uric acid is secreted into the tubules, and then that's how we get rid of it in the urine. Niacin inhibits that, so it can cause hyperuricemia, or increased uric acid in the blood, and then that can predispose a patient to developing gout. Impaired glucose tolerance has been seen sometimes in patients on niacin. And then finally, niacin can possibly be hepatotoxic. So niacin is not recommended in patients who have active hepatic disease. So no niacin, or avoid niacin in patients with hepatic disease, and then also in patients with active peptic ulcers. Next, we'll talk about the fibrates. The fibrates include fenofibrate and gemfibrozole. The fibrates are excellent at decreasing triglycerides. They are the most effective agents at decreasing triglycerides. They also increase HDL cholesterol, and they're really good at this. The niacin is better at increasing HDL, but the fibrates are also really good at it. Their greatest effect, though, is decreasing triglycerides. They have a really small effect on LDL. It's not very big. When we look at how much they decrease triglycerides, fenofibrate is the most effective. Fenofibrate has the greatest effect on triglycerides, but they both do really well at lowering triglycerides. The mechanism of action, they activate PPAR, and PPAR is peroxisome proliferator activated receptor. This is a nuclear receptor, and the nuclear receptor, when it's activated, it increases the expression of lipoprotein lipase. So it increases the amount of lipoprotein lipase that's present in the cell, and this is a lipase, right? An enzyme that breaks down lipids. So the lipoprotein lipase results in a destruction of triglycerides and decreased triglycerides. Because it has such a great effect on decreasing triglycerides, this is how we use it. Fibrates are used for hypertriglyceridemia, right, or high triglycerides. Mild GI discomfort is the most common adverse drug effect with the fibrates, and it typically decreases with time. Gallstones are possible, so fibrates should not be used in patients with gallbladder disease or biliary cirrhosis. Myositis, or muscle inflammation, is possible with the fibrates. Specifically, gemfibrozole increases the risk of myopathy and rhabdomyolysis when it's used with statins. So not fenofibrate, but gemfibrozole. So gemfibrozole is actually contraindicated with simvastatin, and it's really not recommended with any statin. So I would not add gemfibrozole to a statin. And then when patients are on fibrates, any muscle weakness or tenderness should be evaluated. Also, fibrates can increase the INR when used with warfarin. So patients who are on warfarin should have the INR monitored more frequently when the fenofibrate or gemfibrozole is added, or when the dosage is increased. Moving on to the bile acid sequestrants, which do just that. They sequester bile acids in the intestines. Bile acid sequestrants include cholestyramine, cholestyramine, and cholestyramine, which you see down here. Bile acid sequestrants lower LDL cholesterol, but not as much as the statins. Problematically, though, they can actually raise triglyceride levels. So they are contraindicated in patients who have triglycerides greater than 400. The way that bile acid sequestrants work is by forming a complex with bile acids and bile salts in the intestines. And then that complex is large and it's unable to be reabsorbed to recycle those bile acids. Instead, it stays in the intestines and ends up getting excreted in the feces. Because of that, the hepatocytes aren't able to recycle those bile acids and bile salts, so they've got to make more. And they source LDL cholesterol. They get LDL cholesterol from the serum and use that in order to make more bile acids and bile salts. Remember, typically the bile acids are cycled through, they're recycled, right? The liver excretes them in the bile into the intestines. They go through the intestines and then they get reabsorbed and then reused. But when they're sequestered and they're excreted in the feces, then the hepatocytes are constantly having to make more. So essentially, we're taking cholesterol and we're getting rid of it, right? We're constantly getting rid of it in the feces. These can be used for type 2A and 2B hypercholesterolemia. They're typically used in combination with other agents, though, like with niacin, for example, or combined with diet, lifestyle changes. Cholestyramine specifically can also be used for the pruritus that's associated with biliary stasis. And then colesevelam, ironically, has a glucose lowering effect and can be used in diabetes mellitus for that. The bile acid sequestrants are big. They're really large molecules. They're taken by mouth, so they're taken orally, and they're never absorbed into the body. Remember, they work in the intestines and then end up getting excreted in the feces. So they never actually get absorbed into the body. They're not metabolically altered in any way. They simply make their way through the GI tract, and that's where they work. So the most common adverse drug effects then are GI disturbances. So the most common things are constipation, nausea, flatulence is really common. But other than that, there aren't large systemic side effects that occur. However, they do impair the absorption of some fat-soluble vitamins. Because remember, the fat-soluble vitamins, when they're absorbed, they get packed in with fats, right? And that's how they get absorbed in the chylomicrons. So there is impaired absorption of vitamin A, D, E, and vitamin K. Also, bile acid sequestrants can impair the absorption of drugs. So they should not be taken at the same time with other medications, or those medications might not be absorbed. So other drugs should be taken either 1 to 2 hours before the bile acid sequestrant so that the drug can get absorbed before this bile acid sequestrant is taken, or 4 to 6 hours after the bile acid sequestrant so that it can make its way through the system before you're taking the other drugs. So the bile acid sequestrant cannot be taken at the same time as the other drugs. We'll finish up with a few adjuvant drugs that are typically added on to other agents when there's more of a cholesterol lowering effect that's needed. Ezetimibe is a great kind of new drug that we can add on to statin therapy. This is a cholesterol absorption inhibitor. It's really well tolerated, and it inhibits the absorption of both dietary cholesterol and biliary cholesterol. It has modest LDL lowering effects, so it lowers LDL by about 18 to 23%, which is not huge on its own, but that's good when it's used in conjunction with maximum doses of statins, or it can be used in patients who can't tolerate statins. It has few reported adverse drug effects, and again, it's really well tolerated. So this is something that's great to add on to a statin without increasing the risk for rhabdo. Right? Historically, we frequently have added on like niacin, for example, but that increases the risk of rhabdo. This does not. So this might be more expensive, but it is a lot safer and has fewer reported adverse drug effects. The PCSK9 inhibitors include alirocumab and evolocumab. PCSK9 is an enzyme that breaks down LDL receptors on hepatocytes. So if you inhibit this enzyme, if you inhibit PCSK9, then you're inhibiting the breakdown of LDL receptors. So that means there's more LDL receptors on hepatocytes, and the liver can take in more LDL cholesterol from the bloodstream. So ultimately, it ends up decreasing LDL cholesterol in the blood. This is given subcutaneously. It's subcutaneous injection once every 2 to 4 weeks. This is also an agent that's used with statins. And when these are added to statins, they can decrease LDL cholesterol from 50 to 70% total. So that's a really huge decrease in LDL cholesterol. It can also be used in patients who are not tolerant to statins. So again, this is another agent that we can add to statins for greater reduction in LDL cholesterol. These are monoclonal antibodies, hence the fact that they're being injected and they're not oral. But because of that, immune-mediated reactions are possible. Allergic reactions are the most common adverse drug events that are seen with these. Yeah, but both of these can be added to statins without increasing the risk of rhabdomyolysis. So that's important to try and avoid that if possible. Omega-3 fatty acids can be used to lower triglycerides. They're not used for LDL cholesterol. They actually may cause a slight increase in LDL cholesterol, but they do lower triglycerides by 25 to 30%. So that's why we use them. Their mechanism of action is to inhibit VLDL and triglyceride synthesis in the liver. And we add omega-3 fatty acids to other therapies in patients with triglycerides over 500 milligrams per deciliter. So in patients who have really high triglycerides, we can add omega-3 fatty acids on. Now, in order to be effective, the patient needs to have 4 grams daily. And that's a pretty high dose. The reason I mention doses, I normally don't make you memorize doses, but the reason this is important is because a lot of patients take omega-3 fatty acids over the counter. And if they're taking them over the counter, they need to make sure that they're getting the recommended dose, that they're getting enough of the omega-3 fatty acids. Omega-3 fatty acids are available or can be sourced from marine sources, so from fish. It's in tuna, halibut, salmon, but it's really hard to get to that 4 grams daily just with dietary sources. So there are OTC fish oil capsules that can be taken. There is also an RX version. It's called, icosapent. So it can be given via prescription as well. These are generally well tolerated. Most common side effects include things like stomach upset, nausea, diarrhea, and then also something that patients complain about is a fishy taste in the mouth. Which kind of like burping up a fishy taste, and that's just, it's not pleasant, but it is really commonly complained about with the omega-3 fatty acids. Last thing I include here, this is just kind of a summary of all of the effects of the different drugs that we use, and then the effect on LDL cholesterol, the effect on HDL cholesterol, and then the effect on triglycerides. So for example, you can see like statins, right? HMG CoA reductase inhibitors have a huge decrease in LDL, small increase in HDL, small decrease in triglycerides. Fibrates, you see that fibrates have the largest effect on triglycerides. second largest effect on increasing HDL. Niacin has the largest effect in HDL, second largest effect on triglycerides. So those two kind of flip-flop each other. You see bile acid sequestrants, pretty decent LDL lowering effect. Our PCSK9 inhibitors, when we use those in conjunction with statins, we end up with a huge decrease in LDL. Okay, so this is just kind of an easy chart to flip to really quickly.